Welcome back to the deep dive. Today, we're jumping into a really interesting medical area, looking at two less common types of pneumonia.
That's right. Cryptogenic organizing pneumonia and eosinophilic pneumonia.
Yeah, and it's fascinating because sometimes symptoms look like one thing, something really common, but actually, you need a totally different approach, different diagnosis, different treatments.
And highlights why digging deeper is so crucial sometimes.
Exactly. So our mission today is to kind of unpack these two conditions. Ready?
To do it.
Okay, let's kick off with cryptogenic organizing pneumonia. COP, I think some people might remember its old name, bit of a mouthful.
Yeah, BOOP. Bronchiolitis obliterans organizing pneumonia. COP is definitely easier.
Definitely. So tell us what's actually going on inside the lungs with COP and how does it, present itself?
Well, basically, COP involves this patchy inflammation where granulation tissue, think of it like abnormal repair tissue, starts growing in the small airways, the bronchioles, and the alveolar ducts. And the tricky part is the presentation looks a lot like regular community-acquired pneumonia. You get the cough, shortness of breath.
Dyspnea, right?
Exactly, dyspnea. Plus fever, feeling generally unwell, malaise, maybe even some weight loss. It really mimics the common stuff.
So that's why it's easily missed initially.
Precisely. But here's the absolute key difference, the big red flag.
Which is?
It just doesn't get better with antibiotics. You give the standard treatment for bacterial pneumonia and nothing happens.
Ah, okay. That failure to respond is the crucial clue then.
Huge clue. It tells the clinician, okay, hold on, this isn't what I thought it was. We need to look elsewhere.
So if it's not a typical bacterial infection driving it, what are the usual suspects behind COP?
It could be triggered by various things, actually. Sometimes infections, yeah, but different kinds. Or it could be linked to underlying autoimmune disorders.
Right. And how do you confirm it for sure?
The gold standard, the most accurate test, is a lung biopsy. You need to actually see that characteristic pattern under the microscope.
Got it. And the treatment, you mentioned it was surprising.
Yeah, well, surprising if you were stuck thinking infection. The treatment is glucocorticoids, steroids, basically.
Yeah.
And they work really well, often resolving the symptoms quite effectively once you get the diagnosis right.
Okay, let's switch gears now to the other one, eosinophilic pneumonia. How does this one typically show up?
It's got its own distinct picture. Often it's someone who's had about, say, 1 to 2 weeks of fever, cough, and shortness of breath.
So similar start in some ways?
Similar start, yeah. But it can worsen and sometimes progress, unfortunately, to respiratory failure.
Oh, wow.
And here's where the detective work really comes in the period. The patient's history is packed with potential clues.
Like what sort of things?
Well, you'd be looking for maybe an underlying cancer or exposure to specific medications, things like amiodarone, NSAIDs, common anti-inflammatories, nitrofurantoin, phenytoin, even daptomycin.
Quite a list.
It is. And another really interesting angle is parasitic infections, things you might not immediately think of, like strongyloidiasis, ascariasis, trichinosis, schistosomiasis.
Parasites, wow. That really widens the net, doesn't it? How seemingly unrelated factors can point you right to the diagnosis.
Exactly. It really emphasizes checking that history thoroughly.
So besides the history, what about tests? Imaging. What helps pinpoint eosinophilic pneumonia?
Imaging is definitely helpful. On a standard chest X-ray, you might see these bilateral reticular densities, kind of like a fine network or lacy pattern across both lungs.
Okay.
And a CT scan often shows what we call ground glass opacity. It looks hazy, like looking through frosted glass.
Right, I see. And the definitive test, like the biopsy for COP.
The most accurate test here is finding eosinophils, that specific type of white blood cell, in high numbers. You can find them either through a bronchoalveolar lavage or BAL.
Where you wash out parts of the lung.
Exactly. Or, again, through a lung biopsy. Seeing those eosinophils is key.
And the treatment is also steroids here?
Yes, interestingly enough. Like COP, the treatment that works for eosinophilic pneumonia is steroids.
Okay, so let's kind of pull this together. We have these two conditions, COP and eosinophilic pneumonia. They can both look a bit like standard pneumonia at first.
Those initial symptoms, yeah. Flu-like, pneumonia-like, very deceptive.
But they have totally different things going on underneath, right? Different triggers, different mechanisms.
Completely different underlying pathology.
Right.
Granulation tissue in COT versus those eosinophils being recruited in eosinophilic pneumonia, triggered by anything from drugs to parasites.
Yet, crucially, they both end up responding well to steroids, not antibiotics.
Exactly. And that's the core point, really. It shows why you absolutely have to get the diagnosis right. You can't just stick with a standard pneumonia diagnosis if the patient isn't isn't responding as expected.
You need to use those clues. The lack of response to antibiotics, the specific history, the imaging, the BL or biopsy results.
To differentiate these conditions. Because getting it right means getting the right treatment, the steroids, to the patient.
That really hammers home the point. Not all pneumonias are created equal, and sometimes you need to look beyond the surface symptoms. Understanding these specific types means better care.
Absolutely. It's about recognizing when the standard picture doesn't quite fit and knowing what else to consider.
A great takeaway.
And maybe a final thought for everyone listening. In this age where we have so much information flying around, how do we train ourselves? Not just in medicine, but anywhere. How do we train ourselves to look past the obvious symptoms, the surface level stuff, and spot those subtle clues, the ones that hint at maybe surprising deeper realities? Something to think about.